we will now move on to cardiac rhythm disorders. The first step to any potential cardiac arrest is make sure the patient is truly unresponsive. It is critical to make sure this patient is not sleeping or just having a syncopal event. Performing chest compressions and giving respiratory breaths on a person who is breathing is counterproductive and dangerous. Next, call for help, call 911, and activate the EMS service. If he is truly unresponsive, start chest compressions and give rescue breaths. After the patient has been shown to be unresponsive and EMS is on the way, the next step is to open the airway, head tilt, chin lift, jaw thrust, check for a pulse and start compressions if pulseless, give rescue breaths if not breathing. Remember, CPR doesn't restart the heart. CPR keeps the patient alive until cardioversion can be performed. The precordial thump has been sensationalized by TV, but when is it the correct answer? When there's been a very recent onset of arrest, that means less than 10 minutes with no defibrillator available, or you know it's recent because you saw it and witnessed it yourself. There are 4 major arrhythmias that can cause a sudden loss of pulse. The first is asystole, ventricular fibrillation, ventricular tachycardia, and pulseless electrical activity. The best initial management for all forms of pulselessness is always CPR, CPR, CPR. When presented with a pulseless patient who is in asystole, besides CPR, the best therapy is epinephrine. Vasopressin is an alternative to epinephrine. What they do is they constrict blood vessels in the tissue and raise your blood pressure. They also shunt blood to critical central areas, such as the heart and brain. The best initial therapy for somebody in ventricular fibrillation is an immediate unsynchronized cardioversion followed by CPR. Unsynchronized equals defibrillation always. Why is that? Well, generally, all electrical cardioversions should be synchronized to cardiac cycle, except for VFib and pulseless VTAC. The reason is in VFib, there is no organized electrical activity to synchronize with, so shock them right away. Only VFib and VTAC without a pulse get unsynchronized cardioversion. Everybody else needs to be synchronized. Now here's an example of a 12-lead EKG with a patient in ventricular fibrillation. Notice there's no organized electrical activity. After an attempt at defibrillation, the most appropriate next step in management is epinephrine or vasopressin, then follow with another shock. Medications do not restart the heart. They simply make the next attempt at a defibrillation more likely to succeed. Amiodarone and lidocaine is given to try to get subsequent shocks to be more successful, and magnesium is given with ventricular arrhythmias without waiting for a level. Lastly, remember, beryllium is always the wrong answer on the USMLE. Ventricular tachycardia is a wide complex tachycardia with a regular rate. The management, however, is based purely on the patient's hemodynamic status. If they have pulseless VTAC, you manage it exactly the same way as if they were in VFib. If they're hemodynamically stable and having VTAC, start with amiodarone, then lidocaine, then proceed to procainamide. If all medical therapy fails you, then cardiovert the patient. Hemodynamically unstable VTAC is managed with electrical cardioversions followed by medications such as amiodarone or lidocaine. Remember, VTAC is managed with shock and drugs and CPR at all times in between the shocks. This short run of non-sustained ventricular tachycardia is very evident by its wide complex and regular rate on this 6-lead rhythm strip. What qualifies somebody as hemodynamically unstable? Chest pain, shortness of breath, hypotension, confusion. If they have these, they're not perfusing. These qualities of instability are the same for all rhythm disturbances. And a little quick tip, if you're ever given the answer choice to give direct intracardiac medication, that's always the wrong answer. Pulseless electrical activity, or PEA, is the rhythm formerly known as electrical mechanical dissociation. This means that the heart is electrically normal, but there's no motor contraction. In other causes of PEA, the heart may still be contracting, but without blood inside, there will be no meaningful cardiac output. Here's an example of pulseless electrical activity on a V2 and V3 rhythm strip. We synchronize the delivery of electricity and cardioversion of VTAC to prevent worsening of the arrhythmia into something like ventricular fibrillation or asystole. When you have PEA, look for a normal EKG and no pulse. To treat someone in PEA, you must always correct the underlying cause. The causes of PEA can be tension pneumothorax, The H's: hypovolemia, hypoglycemia, hypoxia, hypothermia, metabolic acidosis, and look at this, hyper or hypokalemia can cause PEA. A massive PE could do it, as well as a tamponade. Atrial rhythm disturbances are rarely associated with hemodynamic compromise. This is because cardiac output is dependent upon the ventricle, not the atria. Look for the following findings in the history to suggest someone is having an atrial arrhythmia. The first is palpitations, dizziness, lightheadedness, exercise intolerance, or dyspnea. And lastly, if they had an embolic stroke, you got to look at the heart as the source. When reading the vignette, if you come across irregularly irregular rhythm, this suggests AFib as the most likely diagnosis even before the EKG is done. This is because AFib is the most common arrhythmia in the United States. Atrial fibrillation and atrial flutter are two disorders with nearly identical management. So how do they differ? Well, atrial flutter is a regular rhythm, whereas atrial fibrillation is irregular. Lastly, atrial flutter is extremely indecisive. Sometimes it can change into sinus rhythm. Other times, it can bounce into fibrillation. Here's a 12-lead EKG with somebody in atrial fibrillation. Notice the irregularly irregular rhythm. Here's a 12-lead EKG of somebody in atrial flutter. Notice how there's a sawtooth pattern and a regular rate. Hemodynamically unstable atrial arrhythmias are managed with synchronized cardioversion. The reason for synchronization is to prevent the electricity from being delivered during the refractory period. That period is the STT wave. Synchronization also helps prevent deterioration into VTAC or VFib. Hemodynamic instability, as it is defined for VTAC, is hypotension, confusion, development of CHF, or chest pain. By definition, chronic atrial fibrillation is defined as lasting for more than 2 days. However, after 7 days, there is a risk of clot formation, but routine cardioversion is not indicated. The majority of those who are converted into sinus rhythm do not stay in sinus. Atrial fib and flutter are caused by anatomic abnormalities of the atria from hypertension or valvular disease. Shocking the patient into sinus rhythm does not correct a dilated left atrium. Over 90% of these patients will revert to fibrillation even with the use of antiarrhythmic medications. Therefore, rate control and warfarin for anticoagulation is the standard of care for AFib. Chronic AFib should be anticoagulated before cardioversion. Unstable, acute disease does not need anticoagulation. The best initial therapy for fibrillation and flutter is to control the rate with beta blockers, calcium channel blockers, or digoxin. Our goal heart rate is less than 100. The next step after rate control is to give warfarin until the INR is between 2 and 3. So remember, slow the rate and anticoagulate. Lastly, rate-controlling drugs do not convert a patient into sinus rhythm. So if you're given this as a choice, don't choose it. The two calcium channel blockers used to control heart rate with atrial arrhythmias are diltiazem and verapamil. This is because they actually block conduction at the AV node. The other calcium channel blockers only control blood pressure. Remember, no matter how much you might think it's better to shock every patient to sinus, it just doesn't work in the long run. Without anticoagulation, there will actually be about 6 embolic strokes per year for every 100 patients, thus a 6% a year stroke risk. When the INR is actually maintained between 2 and 3 reliably, the rate drops to 2 to 3%. You need to use heparin before warfarin only if there is a current clot in the atrium. Remember, there are 2 new drugs on the market, dabigatran and rivaroxaban. They may show up on your exams. These are alternatives to warfarin. They are for non-valvular AFib. And the great thing is, you don't need to monitor the INR. Atrial fibrillation is caused by anatomic cardiac defects that dilate the atrium. These defects do not go away with cardioversion. That's why the vast majority revert. Many patients with acute AFib from alcohol use, caffeine, cocaine, or transient ischemia will simply convert back to sinus rhythm on their own. Therefore, acute disease normalizes spontaneously, so don't force it. And chronic disease reverts into arrhythmia as well, so don't force it either. Atrial rhythm problems can cause acute pulmonary edema from the loss of atrial kick in those patients with a pre-existing cardiomyopathy. Patients with a low risk of stroke can have their embolic phenomenon safely prevented with using aspirin rather than warfarin as an anticoagulant. If the annual risk of stroke is only 2 to 3% per year, there's no point in subjecting them to the 1% a year risk of major bleeding. This is called the CHAD score. It stands for congestive heart failure, hypertension, age greater than 75, diabetes, and a prior stroke or TIA. Anyone with a CHAD score greater than or equal to 2 should be on warfarin, dabigatran, or rivaroxaban. Major bleeding from warfarin is defined as having an intracranial hemorrhage or at some point requiring a transfusion. The criteria for low risk of stroke from AFib, that means to be able to use aspirin, you must not have cardiomyopathy, congestive heart failure, or atherosclerosis, no hypertension, an age less than 75, no diabetes, no stroke in the past. Thus, the answer for management of lone AFib is rate control, but you can use aspirin as opposed to warfarin or dabigatran. Supraventricular tachycardia presents with palpitations in a patient who is usually hemodynamically stable. The best initial step is vagal maneuvers, such as carotid massage, valsalva, dive reflex, or ice immersion. If those don't work, proceed to adenosine. Remember, adenosine can only be therapeutically used for SVT. This is then followed by beta blockers such as metoprolol, calcium channel blockers such as diltiazem, or digoxin if adenosine is not effective. Here's a 12-lead EKG showing no P waves or fibrillatory waves. The QRS is less than 100 milliseconds, and the rate is 160 to 180. The complexes are narrow. This fits SVT. Wolff-Parkinson-White is an anatomic abnormality in the cardiac conduction pathway. They're going to present it to you with 3 different scenarios. The first is SVT alternating with ventricular tachycardia. The second is SVT that gets worse after diltiazem or digoxin. And last, if you see a delta wave on the EKG, click Wolff-Parkinson-White. Remember, vagal maneuvers slow and convert SVT. They don't work at all with atrial fibrillation. On this 12-lead EKG, we notice a short PR that's less than 120 milliseconds and a delta wave at V2 and V3. This is classic Wolff-Parkinson-White syndrome. Remember, the short PR is due to early depolarization of the ventricle. The most accurate test for Wolff-Parkinson-White is cardiac electrophysiology studies. Procainamide or amiodarone are both useful for atrial and ventricular rhythm disturbances. Use them only if Wolff-Parkinson-White is currently presenting with an arrhythmia. Radiofrequency catheter ablation is curative for Wolff-Parkinson-White. The tip of the catheter is heated and simply ablates or eliminates the abnormal conduction tract around the AV node. EP studies actually tell you where the anatomic defect is. Digoxin and calcium channel blockers are dangerous in Wolff-Parkinson-White. They block the normal AV node and actually force the conduction into the abnormal pathway. Multifocal atrial tachycardia is associated with chronic lung diseases such as COPD. Job 1 is always to treat the underlying disease. For the rhythm, treat MAT as you would AFib. But remember, avoid beta blockers as they are detrimental in lung disease. This is a classic EKG demonstrating multifocal atrial tachycardia. Note the different morphologies in the P waves. You have to have at least 3 different ones to be considered MAT. A woman comes to the office for a routine evaluation. She's found to have a pulse of 40, but an otherwise normal history and physical exam. What is the most appropriate next step in the management of this patient? Yes, the correct answer is C. Bradycardia is common. The normal heart rate is between 60 and 100. Some people just have one that's below 60. Those are usually athletes, people who are runners, joggers, etc. Bradycardia, however, can also be the initial presentation of somebody with a 3rd degree or complete heart block. An EKG is mandatory to distinguish the causes of bradycardia. Atropine is the wrong answer because you do not give someone who's asymptomatic, and you also do not know the rhythm yet. A pacemaker is a little too invasive at this point. It is used for a symptomatic patient who does have 3rd degree AV block. Electrophysiology studies seems a little too invasive at this point. Epinephrine is dangerous since ischemia can precipitate after giving it. Isoproterenol is an old, rarely used, non-specific beta agonist that speeds up the heart but also causes ischemia. And lastly, doing nothing is never the right answer. Just a tip, on your USMLE, if you're ever presented with an answer choice of isoproterenol, cross it out. It's never the right answer to anything. If a patient presents to you, as in the previous case with sinus bradycardia, and they are asymptomatic, no treatment is indicated. However, if they are symptomatic, you must use atropine as the best initial therapy and a pacemaker as the most effective therapy. A first-degree AV block is managed the same way as a bradycardic patient. Atropine and pacemakers are used only if the patient is symptomatic. Now, there are two kinds of second-degree AV block. Remember, the first one is Mobitz 1 or Wenke block. This is a progressive lengthening of the PR interval and eventually results in a drop beat. Mobitz type 1 is most often a sign of normal aging of the conduction system. If there are no symptoms, it's managed the same way as sinus bradycardia. That means don't treat if they're asymptomatic. And here's an example of Mobitz type 1 or Wenke block. Another form of second-degree AV block is Mobitz type 2. It's a great deal more pathologic than Mobitz type 1. Mobitz type 2 just drops the beat without a progressive lengthening of the PR interval. This is very dangerous for the patient. Mobitz type 2 also has the potential to progress and deteriorate into third-degree AV block. Therefore, we treat it like a patient who has a third-degree AV block. Everyone with a Mobitz type 2 block gets a pacemaker. That's even if they're asymptomatic. Here's an example of a rhythm strip, lead 2 of Mobitz type 2 second-degree AV block. Note the drop beats. Here's an example of a complete heart block, the third-degree AV block. There's complete atrial and ventricular disassociation. The P waves and T waves have no fixed relationship to each other. A 58-year-old woman is admitted to the hospital with an acute MI. On the second day, she develops sustained VTAC, even though she's on aspirin, heparin, lisinopril, and metoprolol. What is the most appropriate next step in the management of this patient? Is it A, increase the dose of the beta blocker? Is it B, add diltiazem? Is it C, an angiography? Is it D, an implantable defibrillator? Or is it E, perform an EP study? That's right, the correct answer is C. The most common cause of death in the 72 hours surrounding an acute MI is ventricular arrhythmia. Manage arrhythmias from ischemia by correcting the ischemia itself. Therefore, perform an angiography for possible angioplasty or bypass. Increasing the dose of metoprolol won't treat the ischemia. Adding diltiazem will not affect this rhythm. An implantable defibrillator isn't quite right yet because the patient's underlying cause can be fixed. And an EP study won't be appropriate because this VTAC is not from an ectopic site, but rather from ischemia. Which of the following tests would you do to determine the risk of recurrence in the patient in the previous example? Is it A, an electrophysiology study, B, an echocardiography, C, a MUGA scan, D, a VQ scan, or E, tilt table testing? That's right, an echo. Why is that? LV function is the most important correlator to the risk of recurrence. Now, the wrong answers. EP studies at this time are really for unexplained syncope. A MUGA scan, yes, is more accurate, but you wouldn't do it before the echocardiography. Also, we use it to check for perfusion. A VQ scan is really for somebody who's had a PE. And lastly, tilt table testing is not appropriate at this time. It's really just for syncope. A 73-year-old male has his third syncopal episode in the last 6 months. An EKG in the field shows VTAC. His stress test is normal. What is the most appropriate next step in the management of this patient? Is it A, give metoprolol, B, diltiazem, C, angiography, D, an implantable defibrillator, or E, EP studies? That's right, the correct answer is D. An implantable defibrillator will prevent the next episode of sudden death or syncope. Metoprolol is not sufficient when syncope or sudden death has occurred. Calcium channel blockers such as diltiazem are useless in preventing or treating VTAC. He's had no chest pain. His recent stress test is normal, so he doesn't need an angiography. And EP studies is useless when the person has a known etiology of syncope on the EKG. A 46-year-old man has intermittent episodes of palpitations, lightheadedness, and near syncope. His EKG is normal. The echo shows an EF of 42%. A Holter shows several runs of wide complex tachycardia lasting about 5 to 10 seconds. Which of the following is most likely to benefit this patient? Is it A, pacemaker, B, digoxin, C, warfarin, D, an EP study, or E, a Swan-Ganz catheter? The correct answer is EP studies. These are useful in detecting a source of ventricular arrhythmia. A pacemaker is not correct because we don't know the underlying cause yet. Digoxin doesn't do anything for ventricular arrhythmias. Warfarin's not correct because he does not have a high risk for a clot. And Swan-Ganz catheters are for diagnosing shock.